Heart failure is one of the commonest causes of admissions for patients over the age of 65 in the United Kingdom. Therefore, in the South East, where we have a particularly elderly population, this is a rising problem for us. We are becoming increasingly aware from what's going on with American performance management and the thinking in NICE and quality standards that capturing the total package of care is fundamental to delivering improved outcome. Heart failure is one of the core components of the Enhancing Quality programme, looking at not just hospital but community, looking at how both those areas deliver heart failure care so as to improve not only how it works but how it's joined together for patient benefit.
The EQ programme has highlighted heart failure as more of an issue. It's become higher on the agenda for the Trust, and it's also helped us to relook at our pathways and redefine our pathways so they're much more streamlined across secondary and primary care. We've introduced a stamp to identify patients more readily and get them onto the right pathway. We've also introduced a transfer of care document, which means that we can document what education and what treatment the patients have actually had while they're in hospital, and then that can be carried on in the community.
Most of the patients that I talk to are finding real benefits from having a formalised care plan which details how their conditions are going to be managed, but also they're coming out from hospital with a lot more information and are better prepared for the challenges in front of them.
The main challenge, I have to say, when EQ first came out was a lot of scepticism between consultants, but I think those who have a passion to develop the heart failure service, we used it really as a vehicle to try and make that change. And once I think we've got everybody on board, it made things a little bit easier to use it in a positive way.
It's one thing to have the data and present it, but people need permission to think differently. They need to be given examples of ways to change their practice or to enhance their practice through their team. The collaboratives work by giving them the opportunity to meet and talk to people doing the same thing in a different way and getting perhaps better or enhanced results. In that sense, they're pretty much unique. I think the collaboratives add a second value. I think if you're giving the data back to the clinician in a public forum, I think that again is quite a strong incentive for the individual clinicians and their teams to seek out best practice from their colleagues.
One of the main benefits from the EQ programme that we feel is that patients are being contacted or being seen within 2 weeks from their point of referral to the heart failure nursing services. We feel that's a real benefit for the patients, but also it's driven forward the quality of the services that we're providing.
How has the EQ process improved clinical practice? I think, to me, two key areas. The first is identifying the patient when they come into a hospital, getting them early, gathering them quickly and intervening. That, for me, means you're including everyone. And I think the second component is the interface between the hospital and the community. It's not an exaggeration to say it's a gulf, and what EQ is providing is a process that bridges that gap and enhances communication between the two tribes of healthcare.